Welcome to Reducing Risk, a series of podcasts from the Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medical legal issues in our jurisdiction and provides hopefully helpful advice and guidance on how to manage those risks. This current series focuses on demystifying the Medical Council standards. So today we're going to be talking about the professional standards in New Zealand with regard to sexual boundaries. And look, this is a topic that always seems to generate some pretty shocking headlines in the press. And I think most doctors think, well, that's not going to be me. I'm never going to do that. So I don't really need to worry about this Medical Council statement. But unfortunately, I think we do all need to look at this statement, and we all do need to think about how it may affect us. There are two main aspects of the issue that we're going to be talking about today. The first is in respect to sexual relationships with patients. And I think we all know that doctors are not allowed to have a sexual relationship with a patient. That's pretty clear. But as always, there are some grey edges in these topics. And then you can think, well, what constitutes a patient? If I saw a person in an outpatient setting 2 years ago, does that make them my patient? What about if I'm a GP and I saw a child with their parents present? Is the parent considered my patient? And then what's considered as a sexual relationship? Is a kiss inappropriate? Is a hug inappropriate? So we can talk a little bit about that and actually what would be considered inappropriate or not. And then the other aspect, and it's probably one that we deal with more often at Medical Protection, is that issue of the breaching of sexual boundaries within a consult. And this often happens where a patient alleges that something's occurred in the consultation room that was sexually inappropriate. It can be very difficult to defend these accusations because often it was only the doctor and the patient in the room. And so it actually makes doctors pretty vulnerable sometimes to these kinds of accusations. So my name's Lucy Gibbon, and I'm one of the medical legal consultants at Medical Protection Society, and I'm here today with my colleagues Tim Cookson. Hello, Tim.
Hi, Lucy.
And Sam King. Hello, Sam.
Hey, Lucy.
So Tim and Sam are both medical legal consultants as well as GPs, and then we're very lucky today to have Amy Creedon with us from Wootton Kearney, who's one of our panel lawyers. So hi, Amy.
Hi, Lucy.
Fantastic. And look, we're going to start with some of the boring bits, which is the definitions. And we know that the terms like sexual impropriety, sexual transgression, sexual violation, you see them in newspaper articles, but do we know what each of those things mean and what the Medical Council considered them to mean? Now, luckily, the Medical Council has helpfully explained them in their statement. So I thought we'd share this with you. And the lowest level of sexual misconduct is sexual impropriety. And this is any behaviour that is sexually demeaning to a patient or demonstrates a lack of respect. So Tim, what would be examples of what the Medical Council would consider to be sexual impropriety?
Well, your example you gave of a hug before is one of those ones that could be a sexual impropriety, or it could be completely innocent. A colleague of mine had a large number of elderly Greek women as patients, and so she could not escape getting a hug at the start of the consultation, at the end of the consultation, and sometimes during the consultation as well. So if that was regarded as being sexual and proprietary, that colleague was going to be in significant difficulty. But I don't think that kind of hug was. But there are some hugs that, of course, could be sexually improprietary. It's the close hugging with various other arm movements which might be easily misconstrued as being not appropriate. Now, look, the obvious one, of course, is doing an intimate examination without consent. So that would be a rectal examination of genitalia. That's a pretty barn door sort of thing, and I think everyone would clearly understand that. But then it gets onto the sort of slightly looser but still unacceptable things, such as making inappropriate comments about a patient's body or maybe the underwear that they're wearing, making any sexualized or sexually demeaning comments to a patient. It might be making an irrelevant comment about a patient's sexual orientation. It could even be asking inappropriate details of a sexual nature or sexual history where it's really not relevant to the consultation. And we've certainly had cases where patients have misconstrued that. It was in fact relevant, but the doctor didn't explain before asking the questions why it was relevant, and then have the patient's understanding, oh yeah, actually I understand why these questions are going in this direction. So for example, a female patient with dysuria, you may well need to ask about sexual activity. But if you just launch into it, that could easily be construed in the wrong way. And also very important, it's not appropriate to be talking about your own sex life when you're talking with your patients about anything relating to their difficulties. That covers some of the
things that are considered sexual impropriety.
I've had a case where a doctor had a very good rapport with a particular female patient, and he would often use what I would describe as edgy humour with her. And this, they'd had this therapeutic relationship for a long time. There was nothing improper about it. But there was one particular consultation where he used that edgy humour in an inappropriate moment. And that created a significant complaint for him. So I think, we do need to be careful about the familiarity we have with patients and our humour, because I think that can be viewed as being inappropriate.
Even just the words we use sometimes as well, because sometimes you might be using words to try and put people at their ease, but if they find those words offensive, and actually that could be considered sexual impropriety.
And sometimes our patients can make it slightly difficult for us. I vividly remember one patient who used to tell very graphic sexual jokes while she was having her smear done. It's remarkable. So,
right.
But it's not good for the doctor to be doing that.
No, absolutely not. Okay, so one level up from sexual impropriety is a sexual transgression. And that includes any inappropriate touching of a patient of a sexual nature short of sexual violation. So, Sam, have you got any examples of what the council would consider to be sexual transgressions?
Sure. I think that when we do intimate examinations, that we ought to be wearing a glove, and we're thinking obviously of genital or anal examinations. It's very unusual to hear of any clinician not using a glove in those situations. But it's interesting that sometimes patients themselves feel or recall that the doctor didn't wear gloves, even though they probably did. But that would be considered a sexual transgression. We've obviously had a number of cases where there have been inappropriate examination of women's breasts, where there's been no clinical indication, or where a patient may have come in for a different reason, and it's seemed as though the doctor has opportunistically done a breast examination. And as a one-off, usually that wouldn't come to our notice, but we've had cases where this has been a consistent practice of some clinicians, and that does get them into trouble.
Okay, so those are the sexual transgressions, and as I said, that's a step up from the sexual improprieties. But then the highest level would be the sexual violation, which is essentially the act of raping a person or unlawful sexual connection. And that's defined under the Crimes Act as a connection introducing the genitalia or anus of one person other than for genuine medical purposes of a part of a person's body or an object. Now, the actual Crimes Act has got that line in it, otherwise than for a genuine medical purpose. And so it basically means that as doctors, we have a genuine medical purpose for a genital or a rectal exam. But if we didn't, then actually that would be considered as a sexual connection under the Crimes Act, and actually as such considered extremely seriously. So today we're going to talk about how... Oh, sorry, Tim, do you want to say something?
Well, when I talked about doing intimate examinations, of course, that was what I meant to explain is that's without consent.
Of course,
so it's, and that sort of comes back to this point about the sexual connection bit. But another thing that's important, increasingly important, in fact, is if you are doing those examinations, not only do you need to get consent, but to record that you've obtained consent to do those examinations.
Absolutely. And also offered chaperones is the other thing, but I think we're talking about that again in a later podcast. So look, today we're going to talk about how very stringent those rules are, and I thought we'd just start with a case example. Now, this case is actually made up, but it does involve aspects of various cases that we have assisted with. So I can very clearly imagine this one happening. So imagine you're in your clinic. A 28-year-old female patient that you have not met before presents complaining of pain in her groin. She thinks she hurt herself at the gym. She's wearing jeans, so you ask her to remove them so that you can examine her. And you direct her towards the bed, which has a curtain. But the edges of the curtain are not completely closed. You examine her as normal, and then a week later the practice receives a complaint, and the patient has alleged that you touched her inappropriately and that you contacted her vulva with your ungloved fingers when you were doing that groin examination. Well, Tim, I think we can all imagine this is a bit of a nightmare, isn't it?
It certainly is, because examination of the groin, it's part of, for example, an abdominal examination if you're doing it properly, looking for hernia, but it's also very close to areas that are very sensitive. And we have had cases, in fact, where doctors have been accused of inappropriate sexual contact without consent when they've examined a groin without specifically saying, this is what I'm about to do, and explaining it carefully. And although, yes, these kind of accusations such as this one are much more common from a female patient to a male doctor, that's no longer solely the preserve now of male doctors, and we're having an increasing, small but increasing number of female doctors who have had complaints of a similar nature about them. And of course, there's always a possibility with patients who are in same-sex relationships who may also feel. So if I'm a male, I may feel that having a male doctor examine some of my anatomy without appropriate consent and protection would be somewhat offensive.
Yeah, I mean, traditionally it has been something that has been, the male doctors have been very much more at risk of, and I think there are more issues come to our attention where a male doctor has been accused of these types of actions. But I have a case recently with a female doctor as well, where a patient has alleged inappropriate touching. So it's not just the guys. And the problem always is here is, how do you defend yourself? Because there's only you and the patient in the room generally. And in this particular case, the doctor didn't offer a chaperone because actually it wasn't an intimacy examination. It was a hip exam and a groin exam. And I think many of us wouldn't necessarily offer a chaperone for a musculoskeletal exam. I don't know.
No, I'd agree. And I think the only thing I would think you can do to protect yourself is if you have any inkling at the time that you're examining a patient that there is something that you just get that sense that the patient is uncomfortable. I think you need to have a low threshold for pulling back and, asking the patient, are you okay? Would you like a chaperone? If you don't feel comfortable, we don't need to proceed. But it is very difficult because, hard. We have seen a number of false accusations, I think.
And also, doctors. It's this guy. It's a week later that had no idea at the time that there was anything even wrong. Mm-hmm.
Yeah, I think the idea that we can always pick up on those vibes is that's a bit optimistic, really, because I think a lot of them do. The doctors who come to us say completely out of the blue, I just had no inkling that this person was uncomfortable, not a slightest hint.
In the scenario that you've put to us, Lucy, you said that the curtains didn't quite close or come together where the patient is undressing. And I think the more we can do to make sure that patients have absolute privacy, they've got a sheet to cover themselves, you ask if, they're ready for you to come in to examine them, all of those things will help.
Yeah.
But you're right, Tim, a lot of our members are blindsided.
I think the council statement actually specifically says that the patients need to have an area to undress in where they aren't viewed while they're undressing. So you really do need to have curtains or a screen or something in your room so that patients can, undress without you being present.
Or them feeling like someone's looking at them. And even though, doctors that might be busy on their computer typing in their notes or with their back turned, if the patient gets that feeling that someone's watching them for whatever reason, that's often where these things start.
Yeah, I had a case where a patient thought that the doctor was looking in the mirror because the doctor was facing the opposite direction to the bed, but the patient felt the doctor was looking in the mirror watching her undress.
And the other aspect here too is that I think some of these complaints are generated because patients get sort of totally surprised by what's happened. They haven't been expecting it to happen. So me as a doctor, I know what I'm going to be doing as the examination, so I don't need to explain it to anybody. I'm just going to go through the process. But in fact, it's much better to signpost what you're doing, particularly, and the closer you're getting to a more sensitive area, the more you need to explain it and take patients through it and make sure that they're happy for you to do that. And so in this example, she's been asked to remove her jeans. Hopefully, yes, a sheet would have been provided. The sheet's going to be covering over the whole area. And then you would say, look, I just need to move the sheet slightly so that I can just look at this area in the groin where you've got your pain so I can examine it. Are you okay with that? And then no surprises. Yep, that's fine. Carry on.
Yeah, I think that's a very good point, actually explaining to the patient every step of the way before you do anything.
The difficulty is that when these complaints are made, they generally will go to the medical council, won't they? And our experience is that the medical council take this obviously very seriously, but they seem to be acting in more and more conservative ways with regards to these things. And so more often than not, the doctors end up with a voluntary undertaking.
So, Amy, what is a voluntary undertaking?
Well, a voluntary undertaking is a measure that the medical council will use more often as not as an interim step to protect the public's health and safety. The voluntary undertaking will have terms and conditions essentially restricting that doctor's practice. For example, in this case, it would be to have a chaperone for all consultations with women within a certain age range. It is voluntary, so it doesn't sound that bad, but it can have a huge impact on a doctor and his or her practice, especially if that doctor doesn't have, say, another registered health practitioner available to fulfill that role, because the medical council are looking for chaperones to be registered health practitioners these days. And the costs also for that chaperone, it's not just being there, it's actually reporting to the medical council because audits are done, ensuring notes are up to date and recording there's a chaperone and so forth. That cost will lie with the doctor, the subject of the voluntary undertaking.
So that means if you had to have a chaperone for every female patient that you see, I mean, that's potentially a huge chunk of your day. You're having to employ a nurse to be there. Absolutely.
It's really burdensome, and that's why it's important when you're asked to sign a voluntary taking to take advice from medical protection or the lawyer assisting you about it to make sure it is not too broad. They have to be proportionate to the circumstances. So from this case, we'd be pushing to try and, for all consultations, say for intimate examination, within that certain age range, and that would limit it somewhat.
Is it voluntary?
It is voluntary. The medical council can't make you sign it, but there will be consequences that will follow if you don't. They can issue a Section 34 risk of harm notice, for example, and it usually is a signal that conditions will be required when full council comes to consider the notification.
But we do challenge them, don't we?
Yep, absolutely. And I have got cases where the NTT in the first instance has recommended a voluntary undertaking, and we've objected to that, and full council has agreed and not looked to enforce or ask the doctor to sign a VU or go to conditions. But for cases of this nature, you would see conditions following if a VU wasn't signed.
There was actually a court case, wasn't there, in 2018, Kamal versus the Medical Council, where they appealed the voluntary undertakings requirements, where I believe the allegation had been that the doctor had inappropriately touched the breast of a female patient during a consultation about a sore shoulder. And look, the doctor had the support of their colleagues and the medical director of the medical centre, and the complainant had actually complained to the police, who decided not to take any further actions. And the judge in that case actually did note that the complainant hadn't actually been required to give a statement under oath to anyone before this voluntary undertaking was suggested, and the judge held that the condition placed on the appellant wasn't fair. But this actually wasn't. I don't think this was actually a voluntary undertaking, was it? This is when it had actually got past that.
Yes, so the medical council had ordered that conditions.
It was a condition rather than a voluntary undertaking.
And it was argued by the doctor that a voluntary undertaking would be sufficient.
Yeah.
And the medical council didn't agree, but the court upheld the appeal.
Which is good. So, in fact, the doctor ended up not having to have the conditions that were going to be imposed, and the judge modified the voluntary undertaking so that it was actually that they didn't need a chaperone for certain consultations, but they did for breast, rectal and pelvic exams on female patients, or if it was requested by the patient. So that was an example of where the conditions were reduced by the court.
Yeah, so the court quashed that decision by the medical council and ordered the voluntary undertaking and modified it, as you've said. And that's on the argument that it actually wasn't fair, reasonable, or proportionate. And that's what I'm saying. That's why it's really important when you are presented with a VU, not just to blindly sign it, to actually look at it in the circumstances, because often they are just, it's easy, sometimes they are standard form and you see them and they're not always applicable, and they can be narrowed down and confined whilst ensuring the public are safe.
It has a big impact, doesn't it, on clinicians when there's an accusation made that haven't even been proven, and knowing how long it takes for these medical council processes to be completed. These VUs can be in place for months and months.
Yes, they can now.
I had one poor chap who lasted for significantly longer than a year, and it was for what turned out to be a totally fictitious complaint. He was required to have a chaperone for all female patients, including if it was a mother who brought her child in, he had to have a chaperone for that consultation. And some of the delays were because it went to the police, but the police couldn't do anything about it. There were no witnesses, so it couldn't go anywhere, but they just sat on it. And we had to threaten the police with the Police Complaints Authority to then get them to make a decision to close the case, because the medical council refused to do anything until the police had closed their case. So it was kind of triple jeopardy for this poor doctor, and really tough.
And it is expensive as well, isn't it?
Yeah,
it has the stress and all those other issues with it. But on the basis of an accusation where nothing has been proved, it feels like the doctor's being punished before there's been anything proved.
And just think about the impact of having a sign up in the waiting room saying Dr. X must have a chaperone for all female patients. What does the rest of the population that go into that waiting room assume has happened? They're not going to assume that he's, a perfect character and this is just a nice precaution, because Dr. Y doesn't have the same chaperone requirements. So rumours around the community, distress for the doctor as a result of that. It in all kinds of areas, it's a huge impact.
It's really hard, isn't it? And we see so many similar cases to this where an accusation has been made.
Yeah, and one of the things that I have concerns about is that I don't think the medical council really considers the opportunity cost. So they're saying we're all protecting the public, but actually there are costs to what they're doing. They're actually reducing the trust of the public in that doctor because they require him to have a chaperone, whereas in fact it turned out that was not required at all. And that's not good.
And for some that cannot meet those requirements under the voluntary undertaking, say having another registered health practitioner there, they can't practice anymore.
Yep. So patients go without a doctor because.
But I do think there are some of the cases, as you said, Tim, where the patient has genuinely misinterpreted the examination and that the doctor has done what they consider to be an appropriate examination, but it really wasn't what the patient was expecting. And so that the patient genuinely does, feel that the sexual boundaries were breached, and the doctor genuinely feels they weren't, but actually there is, on both sides, some understanding there. So, Tim, I think you had a recent case, didn't you, about a baby being examined?
Yeah, there certainly was a case that we were involved with where the mother brought the baby in for another reason, and then towards the end of the consult said, oh, by the way, my son's been pulling at his penis quite a bit, do you mind having a look? And so the doctor said, yeah, happy to have a look, and popped the baby up on the bed. Mother was observing, and he does an appropriate examination. Now, obviously, part of that examination involves manipulating the foreskin to check to see if there's redness or anything like that, or if the foreskin retracts or not. And so the mother interpreted that as being inappropriate sexual behaviour between the doctor and the baby, and laid a complaint, not just with the medical council, but also the police and the HDC. So she went far and wide, and we had talked about before about explaining what you're doing, and it does seem like this could have been one of those ideal cases where if the doctor had explained, but on the other hand, this mother went so far in her complaints that even with a decent explanation, it might not have changed her desire to complain. Yeah.
And what was the outcome?
Sam, do you recall?
Yeah, the police didn't take it any further. They seemingly weren't particularly interested because, according to the mother's story of what happened, she'd basically consented to the examination. She'd asked for an examination of the penis. She agreed to the examination by putting the baby on the bed when asked to and undoing the nappy. And she was right there during the examination. And so the police didn't take it any further very sensibly. And when it went to the medical council, however, they initially wanted a VU for a chaperone for all intimate examinations on anyone under 16, and to advise the parent of the requirement for a chaperone, which was quite draconian, I think, quite harsh, given the situation, the clinical situation. And so MPS challenged this, and the medical council withdrew the requirement, thankfully. The HDC, I think, went on to say that I can understand how the doctor interpreted events in this way, that he'd had the implied consent to examine the baby, but then accepted practices to obtain informed consent prior to conducting an examination. And I think that they meant it in a formal way, and this should include a description of the assessment to be undertaken, which I think is what Tim has already mentioned earlier. And then you would document that in the clinical notes. And the HDC commented, with this in mind, they intended to write to the doctor reminding him of the importance of obtaining and documenting informed consent when undertaking such examinations.
So I ran this past my peer review group and said, how many of you would document that you'd obtained consent to examine a baby's penis when you'd been asked to examine it by the mother? And there was 100% unanimity. No one would record that consent, which really raises the issue, doesn't it? If the HDC is making these decisions about what a reasonable practitioner should do without actually finding out what reasonable practitioners do. And, it's all very well for the HDC to make some decisions, but to kind of make the rules, I think, is not actually their brief anymore.
Interesting, and I agree. I don't think I would have recorded consent in the notes in that situation. I think of all the babies I've examined. But look, how do we protect ourselves from these kind of accusations? Sam, have you got any? I think it is these kind of accusations are a worst nightmare. What can we do to prevent them?
I think initially just being aware that it's possible that these accusations can be made, And it's not just with intimate examinations, as you were saying in that case earlier, where that it was an examination of a groin, or that other case where it's an examination of a shoulder. I think that any time we examine a patient, I think we need to be aware of the fact that they need to know exactly what we're doing and why we're doing it.
I think also having an awareness that there's increasing sensitivity about it. Certainly when I started in practice, the idea of having a chaperone was kind of weird. Why would you have someone else in the room while you're doing an intimate examination? And that has, I think, quite rightly changed. And certainly in the latter part of my career, I'd have the interesting scenario where women whose babies I'd delivered over the years, and I'd be saying to them, would you like a chaperone when I do your smear test? And they'd just look at me with kind of bemusement on their faces and say, you've seen it all before, Tim. Why were you wanting a chaperone? But certainly if I saw a patient I didn't know and needed to do an examination, yep, absolutely, I would say to them, I will be getting my nurse to assist me. And I never had a refusal, but I think if a patient in that circumstance had said, no, I don't want you to have a chaperone, I have said, well, look, I'm sorry, I'm not going to go ahead with that examination. We'll get someone else to do it, someone you're comfortable.
I think that having a notice up to mention to patients if they would like a chaperone, they just need to ask. Often some clinicians will have a pair of shorts available so that people can be examined in a more comfortable way, and ensure that there is a covering or a sheet for a patient and that the curtains do close. I think that's quite important.
Another area where doctors are increasingly getting into difficulties is where they are moving the patient's clothing rather than getting the patient to move it themselves. And I think that's, and I can understand why patients would feel most uncomfortable about having their underwear moved, for example, to view. They'd have no idea of what was going to happen next, and that would be quite an uncomfortable experience. So, don't move patients' underwear, or if you do, make sure you've got absolute explicit consent to do so beforehand.
I think any item of clothing, the patient needs to remove that themselves, or you ask for permission first. I think that's because we seem to have had a few cases like that, haven't we, lately?
And of course, the other thing MPS goes on about forever is the good documentation bit. That if you've offered a chaperone, record that you've offered a chaperone. If there is a chaperone present, they should write their own note saying that they were present, what their role was, and that there weren't any concerns. So look, good notes. That's where we're always going on about, and we continue to do that.
And it's also recording if they decline a chaperone and one's been offered is also useful.
So look, we've used up a lot of our time and we haven't really talked about cases where doctors have faced discipline for having sex with patients. And there are a few of these cases, and look, they're generally widely reported on the front page of the paper. And I'm not sure there's much more we can say about those particular cases, except that we all know that you shouldn't have sex with patients.
That's right. In general, do not have sex with your patients. I think there are circumstances where counsel will accept that it's okay, and it really comes down to how close that relationship was in a therapeutic sense. So if it was a patient that you saw for a minor issue some years ago, that's going to look very different from a patient who has had a mental health issue for years that you've been treating as their doctor. So it's not a never, but it's usually a no to that.
But this is pretty much a zero tolerance with the current patient.
Yes.
I would say that if it's a current patient, it's an absolute no. Tim?
But you can't also, doctors are human, and it's impossible to not predict who you're going to form an attraction to. But the counsellor is very clear that if you have a patient for whom you do form some attraction, that you are not able to cease the doctor-patient relationship for the purpose of then starting a personal sexual relationship.
And on that note, I think if a patient has shown an interest in you as a doctor, shown an interest to pursue a personal relationship with you as their doctor, I think, you'd be strongly advised to move the patient to a different doctor. I think it changes the nature of the relationship, and it would be far safer for everyone concerned to end the therapeutic relationship. Not in order to strike up another relationship, but just to make it.
I have had a case where a doctor ended the therapeutic relationship and then later on developed a sexual relationship with a patient, and the medical council were not at all happy about that. I think you're right. If there's an attraction, you ask them to see another doctor, but that doesn't mean that you can then have a relationship with them.
And I spent a week having a number of phone calls with a doctor who had met up with a patient and decided that actually the relationship that they were forming with the patient was more important than their work as a doctor, and was about to hand in their APC and stop being a doctor.
Wow, that's major. But what about the patient that you see once in an after-hours clinic 3 years ago and then meet them at the tennis club 3 years later? Tim, what do you think about that?
I think, as Sam alluded, that's much less likely to be a concern for the medical council, particularly if the problem that you saw the patient for was something like a musculoskeletal injury, or something very much a one-off. One of the concerns for the council is the inherent power imbalance between doctor and patient. But you'd argue that in that kind of situation where A, there was never a significant ongoing doctor-patient relationship, and then B, a bit of time between the single one-off episode and then the relationship developing, it's pretty hard to argue that there was a significant power imbalance that then influenced the patient into the relationship with the doctor.
Okay. And I think it's, again, we've had several cases where the issue has been to do with if the person had a mental health condition, as you were saying, Sam, that does tend to, where the patient's been particularly vulnerable. We as clinicians, often patients tell you intimate things that they wouldn't tell anybody else, and that being in that position, it often does generate an intimacy that is not normal for a social situation, and that creates a situation where the doctor could use that to then develop a sexual relationship. So that's, I think, what the council's concerned about. So look, I think we've got to the point. I don't know if any of you have got any other bits that you want to talk about, or anything else that you think about these issues. But I think it's just easier to say don't have a relationship. It would, I think, in most situations, the council would look at it. Even if the doctor-patient relationship was in the past, I think they'll still look at it if there's a complaint later on. And I don't know if you guys have had this experience, but it often seems to be that if there is a relationship, that it's actually later when it breaks down that the issue gets raised to the medical council, that actually everyone thinks it's all right at the time because everybody wants the same thing. But the problems are often later. So your patient may say to you, no, it's all right, I won't tell anybody, it's just between you and me. But our experience, I think, would have to be that later on it's not always that way. Would you guys agree with that?
Absolutely.
Very much so.
A man or a woman scorned.
Yeah. And also the fallout for other people, perhaps in a relationship with that patient, the husband or wife. That fallout will often generate a notification.
Absolutely. And this is something that the medical council take very seriously. It is something that would reach the level of discipline in a number of cases, isn't it?
There's certainly a disciplinary investigation,
Yeah.
In fact, I think in the paper yesterday, a doctor had been struck off for exactly this, and won't be eligible to reapply to be practicing for at least 2.5 years.
Yeah, that's significant, isn't it? So look, as I say, probably easy, just don't. But having said that, if you're a member of MPS and you have a particular issue that you want to discuss with us, you're always welcome to give us a call on our 800 number, which you can find on our website. So thank you very much for listening to this podcast this afternoon or this evening. I hope it's been helpful. We look forward to catching up with you in our next podcast. If you like the Medical Protection Podcast, please subscribe and leave a review. If you would like a podcast on a specific topic, please email us on nzpodcasts@medicalprotection.org. Thanks, everybody.
Pleasure, Lucy.
Thanks, Lucy.